What are the current diagnostic protocols for identifying and managing oral potentially malignant disorders?
So this is a two-part question. For identifying an oral potentially malignant disorder or lesion, this really is clinical diagnostics, evaluating a patient, evaluating a lesion, and figuring out whether we're going to consider in our differential diagnosis whether this is something that could be preneoplastic or in that spectrum or category of an oral potential malignant disorder or lesion. Typically, once this has been identified, we biopsy these patients or these lesions specifically, and then that biopsy is sent to a pathologist. And you can get one of a few diagnoses, whether it's dysplastic or non-dysplastic. And then now comes the problem is how do we manage these patients, right? There's no standard or universal protocol in regards to management of preneoplastic lesions or oral potentially malignant disorders. And inherently, we're in a state currently that we're using histologic evaluation, which we are all aware is subjective in regards to coming up with a diagnosis and making our prognostic protocols on how we're going to follow up with these patients. Typically, with dysplasia, we can have either a two-tier system of low-grade epithelial dysplasia or high-grade epithelial dysplasia, or a three-tier system where it's mild, moderate, and severe epithelial dysplasia. Longitudinal data tells us that, hey, mild dysplasia has a lower risk or lower chance of progression to squamous cell carcinoma. That being said, we're in an era where molecular changes and genetic alterations are what really drive transformation. And histologic grade doesn't necessarily correlate to transformation. So when you come up to a diagnosis of mild dysplasia, you could have 10 individuals that can have really differing opinions on how to manage cases of mild dysplasia or moderate dysplasia. The higher grade dysplasia we typically get, the more agreement there is that there needs to be something proactive in regards to management for that patient. But with low grade dysplasias or non-dysplastic preneoplastic lesions, whether it be leukoplakias or others, there really is no universal agreement or protocol for management. So it really is up to the clinician, and there have been various recommendations made by different academies and institutes, a white paper from Amos, as well as a statement from the American Academy of Rural Medicine. And these are loose protocols. And I think, if we look at the trends, there is a more proactive approach that's being kind of seeped into the literature in regards to management of disease.